All right, hey everyone. I'm Carlos, one of the graduating fours. It's the end of the year, so you probably know me by now. So I'm going to be doing my senior lecture today on something I find very important. I wanted to give a special thanks to Dr. Willis, who I'm not sure if he's here. I know he had to make a flight, as well as Dr. Eddie Rodriguez, who's APD over at Ponce EM residency, and he also did a recent lecture on pediatric ultrasound for this. So, going to be talking about emergency medicine in Puerto Rico, lessons from my family's home. So, Puerto Rico, it's my family's home. It's where my family's from, where many of them still live, and it's a big part of how I see the world, even though I wasn't born there. For a long time, I mostly thought of it in terms of culture, family, and identity. But as I went through medical training, and especially learning more about what happened after Hurricane Maria, I started to understand it differently, more so as a healthcare system under real pressure. So why this talk? Well, I'm Puerto Rican. I actually forgot to put this on. There we go. So part of why I'm talking about this is personal, but it's also directly relevant to us here. Puerto Ricans make up a large part of the population in New York City, and a lot of our patients have direct ties to the island. More broadly, this isn't just a talk about Puerto Rico itself, but this is about how systems, policy, and infrastructure shape the care we provide in emergency medicine. So you might know some of these people or all of them. So you got me, you got Abner, you got Camacho, you got Delgado, you got Bad Bunny. Just kidding. So we come in all shapes and sizes. We all look differently. Yeah. So moving on. So, in the talk today, some objectives are going to be how policy, infrastructure, and disaster can directly shape emergency care. We're going to be talking about the healthcare system and history in Puerto Rico, history of it. They're going to be describing EM practice and training in PR, analyze Hurricane Maria's healthcare impact, as well as identify any misconceptions and dispelling any bias toward Puerto Rican trained physicians. Just disclaimer, I was not trained there, but gotta look out for my Boricuas. Um, Going forward. So, going forward into the history of and healthcare context of Puerto Rico, just at a glance, it's part of the US, but it's not in the same way the United States are. I'm sure we all know it's a territory, but just going over it just in case anyone doesn't. Um, they're all US citizens, and their population is pretty sizable despite being a pretty small island, making up about 1/3 of the total population of New York City as a comparison. But then Puerto Ricans within New York City make up about 10% of the population of New York City, about 800,000 people. But some key differences I want to point out are they don't have any voting representation when it comes to the president, and they get limited federal funding, despite having a lot of need for it. So this is the baseline context. PR operates within the US healthcare system, but not as a state. That means it follows many of the same regulations, but does not receive the same level or structure of federal support. And at the same time, about 40% of the population relies on Medicaid, which is roughly double the United States average. So you have this higher reliance on public insurance, but funding that doesn't scale with that need. And it's not an accidental mismatch, it's actually the result of how federal policy was designed. So why does the mismatch exist? So it comes down to how Medicaid was structured federally for Puerto Rico when it initially was enacted in the 1960s. So unlike the states where Medicaid funding is open-ended, Puerto Rico receives a fixed annual allotment, which is also known as a block grant. And once that funding's exhausted, they receive no more money, and it doesn't get matched like the federal match it does for other states, where depending on the income per capita of the place, the government will match a certain amount of Medicaid expenditures. So Puerto Rico doesn't receive proportionally higher support despite having higher need. And so it's structurally built in the program design. It's not just an incidental underfunding. And then there's estimates show that after Hurricane Maria, Puerto Rico is operating at roughly 1/3 of the funding level of the United States, of the states in the US. So when you take that structure and apply it to a real healthcare system, you start to see downstream effects. So what does this actually look like on the ground? It means less money per patient, often less than half of what states receive per Medicaid enrollee, which translates to fewer available services, longer wait times, and limited access to specialty care. Also, physicians are often reimbursed at around 50% or less of Medicare rates, which makes it difficult to sustain practices and contributes to the ongoing physician migration off the island. So there's an instability there. Hospitals are constantly balancing limited funding, workforce shortages, and high patient need. So the entire system operates under this persistent strain. And then when you layer that onto geographic challenges or a disaster like Hurricane Maria, the system becomes even more vulnerable. So on top of everything else, like I said, providers are leaving the island, which is driven mainly by lower reimbursement, limited resources. And there's estimates suggest that around 300 to 500 physicians have been leaving PR each year since about 2014. And in the last decade, the overall workforce of physicians has roughly decreased from 14,000 to about 9,000, which, as you can tell, would mean fewer physicians are managing an ever-growing higher burden of disease. So, with that background, let's dive into what emergency medicine looks like in Puerto Rico. So this is where geography becomes important. The access to care in PR is not evenly distributed. Most healthcare infrastructure is concentrated in the urban areas, which are mainly around the coast. And here I just highlighted two of the largest cities, which are San Juan in the north, and then you have Ponce in the south. But there's in the more rural parts of the island, the outpatient access is much more limited, and patients will have to travel very far to these more urban areas to get like specialty care if they need it. Of note, over 90% of municipalities which are like the little demographic, like I guess you can kind of compare them to counties. Over 90% of municipalities are federally designated as medically underserved, which is determined using factors such as primary care provider to population ratio, poverty levels, infant mortality rate, and percent of people over the age of 65. And because of that, the ED often becomes the most reliable point of access. So when outpatient access, excuse me, is limited and unevenly distributed, the ED starts to take on a different role, which I'm sure we kind of have experience with this. It's not just a place for emergencies. For a lot of patients, it becomes the main entry point into the healthcare system. But for this reason, patients often present later and sicker. Just for your reference, in terms of like different types of like specialty centers, there's one level one trauma center in Puerto Rico. There's six PCI capable centers, one comprehensive stroke center, but multiple primary stroke centers, and they have four medical schools. So talking about pre-hospital challenges, before 2017, the pre-hospital slash EMS system was pretty fragmented, and it was mainly composed of municipal ambulances, private ambulances, and fire-based. And there wasn't a centralized statewide EMS coordination. And then they had very uneven response times. Just for your reference, in the US, the target response times for EMS are under 10 minutes, sometimes under 8 minutes. But in Puerto Rico, times can be upwards of 10, 20, 30 plus minutes, depending on how rural the area is, which increases reliance on bystander response, including CPR. And just for example, Dr. Rodriguez, when I was speaking with him, he was saying that his parents live in like a more rural area in Puerto Rico and like in the more mountainous region. And he has to actually he had to have them make sure they knew CPR just in case that one of them would have to do it on each other. And he tells them specifically where they would need to go depending on whatever issue they're having. But in 2017, after Hurricane Maria, there was a more coordinated response to create the PR Department of Public Safety, so to improve the disaster response, and they unified those previously disjointed systems. Talking about EM residency training, there are two ACGME accredited EM programs in Puerto Rico. You have UPR in San Juan, and then you have Ponce, where Dr. Rodriguez is APD. They're high volume, for us, maybe not the highest, but high acuity environments with UPR seeing around 50,000 ED visits a year, which is roughly similar to downstate. You have a lot of exposure to trauma, critical care, they're a vascular center, they have fast track, large L&D. And then importantly, graduates from these programs are board eligible and they go on to practice across the US. Of note, talking about physician salary and retention, the salary there for residents is comparatively pretty low compared to the States. With This is specifically for UPR, which is pretty similar for the other um, residency programs, is about 43,000 for PGYs. And then physician reimbursement in general is lower overall compared to the mainland. And there are incentives like Act 60, which is a act that would try to retain physicians, but using like service commitments, giving incentives. But despite that, migration to the mainland continues. So moving forward into talking about Hurricane Maria, which is a very pivotal moment in PR's recent history. Just so everyone knows, it says in September 2017, the hurricane struck Puerto Rico as a Category 4 storm. It affected the entire island and caused a near total collapse of critical infrastructure, including the power grid. And that had immediate consequences for the healthcare system. Why did it hit so hard? So it hit a medically vulnerable population. At By the time it already hit, the PR had higher rates of chronic disease compared to the US, with diabetes at about a 17% compared to 10%, hypertension around 45% compared to 32% in the mainland, and then overall higher rates of cardiovascular disease. At the same time, the population was aging, with the median age increasing to over 41 and about a quarter of the population being over 60 years old. So it's a population that relies heavily on continuous access to care, medications, dialysis, routine follow-up of chronic conditions. But when these systems failed, the people most affected were the ones most dependent on that continuity. So there's a huge collapse of infrastructure after the hurricane. The entire island lost power, affecting essentially 100% of the population. Communications were also devastated. About 85% of cell towers weren't functioning, so they couldn't contact their loved ones in the mainland. That also meant loss of electricity, water access, communication, and transportation all at once. And this created an immediate operational crisis for healthcare before we even start talking about the patient outcomes themselves. And what this made this a sense especially dangerous was that these weren't short-lived disruptions. Um, In some areas, people were without electricity for as long as 328 days, making this the longest blackout in modern US history. And so instead of an acute disaster followed by recovery, Puerto Rico experienced months of disrupted infrastructure, generator dependence, and limited access to medications and routine medical care. Despite that, hospitals remained open, but they weren't functioning like their normal selves. There was a post-Maria assessment that found that 28 of 103 clinical and diagnostic centers were severely damaged. And importantly, 20 of 92 FQHCs had either operational closure or significant limitations. And then in some of the municipalities, these community health centers were the only places that were providing round-the-clock emergency and acute care. And when they're open, they had limited care with unstable power, lack of water, shortages of medication, and difficulty maintaining their staffing and record keeping. So the system was running, but at significantly reduced capacity across these domains. And this is also reflected in how patients were actually using the system after the storm. There was a report from a federal medical shelter in Manatí, which is in the northern coast, that showed that over just 30 days, more than 5,000 patients were seen, averaging nearly 200 patients per day. And one thing that I found important was that the most common complaints weren't like trauma from the hurricane itself. There were infections, MSK issues, chronic disease management. So even outside of the traditional hospitals, the system was dealing with a high volume of patients needing their ongoing medical care. And this all translates into patient outcomes. This impact wasn't just physical, it extended into behavioral health. So there were widely reported anxiety, depression, and PTSD following the storm. There was one emergency clinic that showed 90% of over 2,500 patients that were seen there were referred for mental health screening. And there were also increase in the suicide rates in 2017, representing a 29% increase from the prior year. So the consequences of the storm, they extended beyond immediate injury. They had reflected prolonged stress, psychologically and socially. I am going to skip this for the sake of time, but I can send this later. It's basically just going to be 2 minutes of a woman's shared experience of her mom in the hospital. So going into mortality and outcomes, so the best known excess mortality analyses estimated that thousands of excess deaths happened after the storm. And there's a widely used New England Journal of Medicine study that found that the interruption of medical care for chronic complaints was the primary driver of the excess mortality in the months that followed. So they attributed about 3,000 excess deaths from this. So patients didn't really die during the landfall. They died from delayed care, chronic disease complications, and loss of access to their treatment. So one anecdote after I was speaking with Dr. Rodriguez that really hit hard was he was telling me about one of his colleagues who needed to decide who to give epi to out of two patients that were coding at the same time. Due to medication shortages. And one was a younger patient who had a history of asthma, and the other was an old elderly person with many comorbidities. I'd say just imagine yourself in that situation. Who would you give that to? Is you know, yeah. So. And so Maria exposed vulnerabilities in the system, but brings us to another important conversation, which is how Puerto Rican physicians are viewed beyond the island. And just want to talk about a little bit of perceptions versus reality. I do know, just to preface, I do know like maybe not the current interns, but there were like the ones I mentioned before. Like we have worked with PR trained physicians. They're obviously great physicians, but just in case anyone didn't know, um, Puerto Rican medical students and residents are sometimes misidentified as international graduates, and they're sometimes questioned about their training. And there's sometimes are misconceptions or bias against their proficiency in English. One thing I want to point out is that Puerto Rican medical schools are LCME accredited, residency programs are ACGME accredited. So it's the same training and same standards that are in this mainland US. Another important thing I wanted to point out is most medical education in Puerto Rico is conducted in English. Most of their lectures are in English. All of their exams and all of their board prep materials are all in English. But despite that, the physicians trained there can still face bias or assumptions about their proficiency in English, which doesn't really reflect the reality of their training. So you have this mismatch, the same standards but different contexts, and the difference gets misinterpreted. There was an AAMC survey taken of over 100 Puerto Rican medical students that they found that over 51.4% said they'd receive a notification of an application denial because they were considered an international student. And 43% said that they were asked to provide documentation or proof of their U.S. citizenship. So this matters because this affects who gets trained, where physicians go, and ultimately access to care for the patients. And despite match rates of over 95%, these challenges persist. So it's not really about the quality of the training, it's about the perception of it. And just one kind of encouraging stat I saw is that Ponce Health Sciences University in 2025 achieved a 96% match rate. But on the flip side, many of these soon-to-be residents, because of the system there, are going to the mainland. 68% of them matched into the United States. So there have been real improvements since Maria. So there's been, especially in federal funding and efforts toward Medicaid parity. So it's closer to 75 to 80% now, compared to the United States. And at the same time, the system continues to rebuild. The training environment remains strong with a growing number of residency positions. And physicians coming out of PR are trained to adapt and practice effectively, even in these challenging systems. Some take-home points. PR operates within the U.S. healthcare system, but not with the same funding structure. Federal policy has created a system where funding is capped, even as need remains high. which is compounded by a higher burden of chronic disease and limited resources, which directly impacts access to care. And Maria didn't actually create these problems. Just as a reminder, it just exposed that the system was already vulnerable, and this healthcare delivery there was not shaped not just by medicine, but by geography, infrastructure, and workforce limitations. Then lastly, the training there is the same, but it's just the difference is the context in which that training is applied. And understanding that context is essential because this isn't just a different healthcare system, it's emergency medicine in my family's home. So these are my references.